This is Heart Rhythm TV, and I am Julie Shea here with another episode of Advancing Allies. I have the honor and privilege of having a very esteemed guest with me this morning, Dr. Michael Ackerman, who is a genetic cardiologist at the Mayo Clinic in Rochester, Minnesota. So welcome, Dr. Ackerman.
Thanks for having me,
Julie.
Julie.
Thank you for joining me today. So we thought it would be great to have a conversation about genetic testing and its role in managing patients with heart rhythm abnormalities. So can you talk a little bit about the clinical utility of cardiogenetic testing for patients with inherited arrhythmias?
Absolutely. So thanks for having me, Julie.
Yeah.
And really, you think of genetic testing, it's not new.
Right.
Some people still think that this is a new thing. The first genetic test came available in the United States in 2003. So we're 20 years now since clinically available genetic testing. And in fact, for Heart Rhythm Society in 2011, I chaired the first document that described what is the state of genetic testing for the various genetic arrhythmia syndromes, the channelopathies, and the cardiomyopathies. And the utility or the impact depends on which disease are we talking about, which genetic heart disease, and what component of the triad of medicine, the diagnostic, prognostic, and therapeutic triad. And now over the last 20 years, we've seen that the genetic tests for almost every one of our genetic heart diseases, long QT, CPVT, Brugada, hypertrophic cardiomyopathy, ARVC, you name it, that there's tremendous impact across all three components. Diagnostically, confirming the diagnosis, enabling testing of relatives. Prognostically, I think about LQT3 very differently than I think about LQT1.
Right.
And therapeutically, we are now on the advent of gene-specific therapies and gene therapies for which you need to know their gene to know are they eligible for that potential treatment modality. So the impact across the triad is huge.
Yeah, it is. And I think, the most important part that you highlighted was, being able to identify these patients and get them into proper treatment.
Absolutely.
Right? So it's very, very exciting. So the guidelines say that genetic testing are the standard of care for patients with these conditions. Why do you believe that the uptake of genetic testing has not reflected these guidelines?
Yeah, it's a real problem. We have to get with the guidelines and not get with the current guidelines, get with the old guidelines.
Right.
Since 2011, we have said that it is a class 1 indication for genetic testing for almost all of the genetic arrhythmia syndromes that's represented in the community of Heart Rhythm Society. And I think the why probably comes down to genetics is just not in the sweet spot of the vast majority of heart rhythm specialists, both pediatric and adult. I think the why is you think about a heart rhythm specialist training, his or her training is probably devoted 95% plus to everything called not long QT syndrome, called not genetic heart diseases. And so it's just not in their comfort zone. And we need to make it more, we need to instill the confidence and the competence that a heart rhythm specialist realizes that if they're going to call somebody long QT syndrome, if they're going to call somebody CPVT, if they're going to make a diagnosis of Brugada syndrome, HCM, and they're not getting the genetic test, they're just not practicing contemporary medicine.
Right.
And it's time for us to step up and get with the guidelines.
Yeah, how can we help them move forward to kind of overcome these issues that they have with executing, doing genetic testing?
It's a great challenge because I think, again, how we've been doing that. I mean, HRS has had programs. We at the SADS Foundation, which I happen to be the president of the Sudden Arrhythmia Death Syndrome Foundation, a nonprofit advocacy organization for families with long QT syndrome, we've tried to help. And it's been an uphill, slow go. I think we're making strides, and yet a paper just came out showing that among patients diagnosed with hypertrophic cardiomyopathy, less than 10% were getting genetically tested. So we still have a long ways to go, because I would argue that unless that patient is an orphan with no relatives and has already received a defibrillator because they already did cardiac arrest, I'll spot you that maybe she doesn't need genetically tested, but everybody else
Right, the family
should be
and
tested.
for family planning purposes, moving
Absolutely.
forward, it's so important, such
Yeah.
an important piece. So what are some of the organization or resources that you would suggest for physicians interested in pursuing genetic testing for their inherited arrhythmia and cardiomyopathy patients? Things like, as you mentioned already,
Yeah.
SADS and GTTA.
Yeah, so the SADS Foundation, I think any heart rhythm specialist taking care of a family with long QT syndrome or the genetic arrhythmia syndromes, they should be plugging them into the SADS Foundation. We are there to support them, to walk that journey with them.
Yeah.
And we also are there for the physicians to help them with resources. We have a toolkit on how to access genetic testing. It's not hard. It
Yeah.
really isn't hard. And there's others. So we have CGTA, cleverly named for the 4 nucleotides
Yeah.
of our genetic code for the Cardiogenomic Testing Alliance. And this is a relatively newer nonprofit organization that's trying to call to awareness that we have this tremendous gap, that we're not doing good in terms of genetic testing utilization.
Yeah.
These families and patients need it, they deserve it, physicians need it, and yet the physicians aren't realizing that they need this information to take
Right.
better care of their patient.
I mean, if I remember correctly, I mean, I believe that the toolkit that I've used before, it's basically that there's a form you fill out and you collect blood from the patient and send it in. Is it any
It-
more than that?
It's easy. I mean, I think the stigma has been that we need to do fancy, complex genetic counseling by a genetic counselor in order to do genetic testing.
Yeah.
And I think that's been part of the problem. And the realization now is every family needs to have counseling about genetic testing, but it doesn't have to be done by a cardiogenetic counselor because there's just not enough of them.
Yep.
And so if that's been the roadblock to a physician or a nurse practitioner securing the genetic testing,
Yeah.
I think we can break down that barrier and show that it's actually really easy to obtain the genetic test. Several myth busters. It's
Yeah.
not that expensive.
Right.
Many cardiologists say, "Well, isn't that test $5,000 or something, and insurance doesn't pay for it?" Okay, that was 20 years ago.
Right.
It's about $250 out of pocket, and insurance companies increasingly pay for it because
Yeah.
they recognize the value of the genetic test, because in a lot of ways, it can result in less defibrillators
Right.
being
Yeah.
implanted.
Yep. And I think, this is certainly an area, too, where APPs can get involved in terms of educating people and spreading the word a little bit. So,
Absolutely.
yeah.
In fact, little secret, uh, I think APPs may be the solution to take better care of families with genetic heart rhythm diseases, because proceduralists, ablationists, people that spent 99% of their career doing atrial fibrillation ablation,
Yeah.
that's not the right home
Right.
for a family with long QT syndrome, CPVT, HCM.
Yeah, so something interesting we can maybe move forward with the allieds in that
Absolutely.
area. So,
Yeah.
well, Dr. Ackerman, thank you so much. It was really, as I said earlier, an honor and a pleasure, to
pleasure.
have a few minutes to speak with you this morning. So this is Julie Shea with Heart Rhythm TV. Thank you for joining us, and subscribe to our YouTube channel.